Question number 10, which of the following profiles best describes his current physiologic state? And we see a confusing table with a bunch of cardiac, physiologic, and clinical variables. So this is a cardiac question. Let's get started with a STEM. A 68-year-old man presents with several months of progressive exertional dyspnea, orthopnea, and ankle swelling. He had an MI 2 years ago and was lost to follow-up. On exam, he has bibasilar crackles, laterally displaced and diffuse apical impulse, JVD, and 2+ bilateral lower extremity edema. And echo reveals global hypokinesis with an ejection fraction of 28%. Man's is not doing okay. Moral of the story. Orthopnea, whenever you see orthopnea, this is a great key to start thinking, this guy's got heart failure. Orthopnea is just positional dyspnea. It happens when you lay on your back. So if you can imagine the lungs here, let's say we're looking at a cross-section of a lung. Okay, so this is a cross-section of the lung. You're looking at like a lateral view of a lung here. This is in the upright position versus in the supine position here on the right. Okay, so now I want you to think like this is not what it looks like, but we're going to be really dumb it down here. Let's say we got some fluid. We got some fluid in the lung. So this is all fluid down here. All right, look at how much of that lung is being taken up by this fluid versus if we lay supine. I'm just going to continue this line across so we're at the same level. Now look at how much of that lung is being taken up by that fluid. It's like half of the lung in the supine position versus maybe a little less than half in upright. Basically, when you go lie supine with fluid in the lungs, it redistributes over a greater surface area, which means you have less surface area that can do gas exchange. So this is why people with heart failure, when blood tends to back up into the lungs, it tends to look like this. The heart can't get blood out of the heart, so it backs up in the left atrium, backs up into the lungs. All right, so just from this first sentence, we probably know he's got some heart failure, especially with ankle swelling too. Again, if it's backing up in the lungs, it's going to back up into the right side of the heart, and then eventually the venous system, and then that'll go to the hands and feet. And then they tell us he had an MI 2 years ago, which confirms that he's probably on his way to heart failure if he doesn't already have it. Bibasilar crackles confirms our suspicion that there's probably fluid in the lungs. Crackles are not pathognomonic for fluid. They usually mean there's like interstitial fibrosis or fluid in the lungs. One of two things. Crackles means interstitial fibrosis or fluid in the lungs for the most part. Here we were already suspecting heart failure and fluid in the lungs, so it helps us to confirm our diagnosis. Laterally displaced and diffuse apical impulse. That's just meaning, right, if we're looking at the precordium here, right, this is someone's barrel chest. Maybe the apex is supposed to be here. Well, maybe now we're hearing it like way over here and this much bigger area. It's laterally displaced and diffuse. Covers more area. So that just tells you the heart is big. With JVD, again, this is along the same lines of our ankle swelling. It's pretty much the same thing. 2+ bilateral lower extremity edema, right? We said that with ankle swelling. There's a lot of repetition here. An echo reveals global hypokinesis. Hypo meaning less, kinesis like kinesiology, movement, less movement. And we're doing an echo, so that means we're looking at the heart. So there's less movement of the heart with an ejection fraction of 28%. If you don't know what normal ejection fraction is, just probably safe to assume that 28% is pretty bad. Normal is 55 to 70%. So we've got this guy with heart failure, and we need to figure out what these physiologic variables are going to be. So we've got left ventricular contractility, afterload, and pulmonary capillary wedge pressure. So whenever you get these tables, there's almost guaranteed to be one that you're not sure about. That's not necessarily true, but let's just assume here that I have no idea what afterload's going to be. Right? I think this one's probably the most difficult of the three to understand. So why don't we start with one that we understand? Start with the ones that you know. So left ventricular contractility. Well, if this guy's got heart failure, evidenced by his low ejection fraction, we know that his left ventricle is probably not pumping blood very well, right? So contractility is probably decreased. So let's cross off anything that says increased or normal, right? It's not normal because we have low ejection fraction, for sure, not normal. Okay, so, and then there were two just from that, right? We're already down to a 50% shot if we guess now. Okay, so again, let's say I don't know what afterload is. Let's jump to wedge pressure. So pulmonary capillary wedge pressure. This is something I just need you to make sure that you know. Wedge pressure, PCWP, is an estimate of your left atrial pressure. Essentially, we put a catheter in to the right side of the heart. We throw it as far as it'll go, get it into the pulmonary trunk, pulmonary artery, and we can't go any further because then it starts becoming capillaries. And killing people is kind of the opposite of our goal in medicine. So we stop it as far as it goes into the pulmonary artery, and then the MIT wizards use some mathemagic to estimate what the pressure is in the left atrium, on the left side of the heart. So maybe you were thinking, pressure in the left side of the heart, that kind of sounds like end diastolic volume or preload. Yes, it is. PCWP is synonymous essentially with your end diastolic volume, which is synonymous with your preload, which is synonymous with your venous return. Like there's a lot of terms that mean slightly different things, but for our intents and purposes are essentially equivalent. So we've got this heart that can't pump blood, evidenced by our low ejection fraction, evidenced by blood backing up into the lungs and then into the lower extremities. So if blood is not leaving the heart, you're going to have more blood in the left atrium, which means more wedge pressure. So just like that, we know that the answer is A because that's the only one that matches. Standardized tests are hard. Who said standardized tests are hard? A lot of people. A lot of people said that. Okay, let's just talk about afterload though. So again, preload is essentially how much blood the heart has to pump. Afterload is the resistance the heart is working against. How many resistors you have in your circuit. How vasoconstricted your blood vessels are. So I need you to think of the two things that regulate blood pressure acutely. Acutely, it would be the heart, right? Cardiac output and the vasculature. All right, we have other things like the renal system, RAS, ADH, but these things are very quick and they're the only things in the table. So that's the only thing I'm going to worry about right now. We know cardiac output is a big problem, right? But is there anything wrong with the vasculature? Is there anything wrong with our arteries' ability to vasoconstrict? No, there's not. We don't have any neuropathies, autonomic neuropathies like that other question. The problem is the heart. So if the heart can't keep up with the cardiac output, the blood pressure falls. Like we talked about in another question, if the blood pressure falls, then our baroreceptors are going to detect that, send signals to the brain to increase sympathetic outflow. So that's going to tell the heart to keep working harder, which it can't. And it's going to tell the vasculature to start working harder, to start vasoconstricting. Vasoconstriction is like adding another resistor into your circuit, and that will increase the resistance, which is analogous to increasing our afterload. So the correct answer is A.